Hello, everyone. This is your host, Mahek Shah, and welcome to a new episode of the Heart Success Podcast, where we discuss practical knowledge and the latest in the field of cardiovascular medicine. All listeners be advised that the podcast is for personal information, education, and entertainment only. Information from this podcast should not be used as medical dictum, and all decisions related to patient care should be made in consultation with care providers. In our third episode today, we're going to go back to some basics. We're going to talk about the data that we have for managing heart failure patients with fluid and salt restriction. Specifically in this episode, we will tackle the topic of fluid restriction. We'll do salt restriction in the next episode.
I know I tell all my patients to watch their labels, know exactly how much water they're drinking, exactly how much salt they're taking, but it's not really that easy. And at the end of the day, what I want to do today with you guys is to review the evidence as to where does this recommendation really come from. One of the cornerstones of non-pharmacological management in heart failure has been restricting dietary sodium intake, and in many cases, fluid intake. Data supporting this approach is somewhat inconsistent, and many studies have shown benefit. Others have demonstrated better outcomes with sodium liberalization. The controversy can be seen even in your guidelines. Your ACC-AHA guidelines for heart failure in 2009 gave sodium restriction in patients with symptomatic heart failure a class 1 recommendation to reduce congestive symptoms. They conceded that the level of evidence was C, but at the same time, 4 years later, when they came up with the updated guidelines, this is the 2013 ACC-AHA guidelines, they sort of downgraded that recommendation for sodium restriction down to 2A. They don't really comment well on fluid restriction overall. So that's the reason we're here today. We're here really to talk about fluid intake first.
We have a guest today, Dr. Peter Johannson. Dr. Johannson is a PhD and professor at Linköping University in Sweden. He currently works at the Department of Social and Welfare Studies and the Division of Nursing Sciences at Linköping University. His research is mainly in nursing sciences, cardiovascular medicine, and psychosomatic medicine, with close to 100 peer-reviewed publications. As Dr. Johannson states in his bio, the words "a focus on the heart" are a great way of summarizing his professional work. He combines clinical work at the Heart Clinic with his own research, and his teaching is focused on evidence-based care and treatment of patients with heart disease. Dr. Johannson and his colleagues from Linköping University and the University of Groningen in the Netherlands published one of the only papers out there where they assessed and performed a sophisticated review of the current literature in the field of fluid restriction and heart failure. They published their findings in the European Journal of Cardiovascular Nursing in the year 2016.
So Dr. Johannson, welcome to Heart Success Podcast.
Thank you very much. Thank you for being invited.
Thank you, Dr. Johannson. And could you tell us a little bit more about you and what you do when you're not working, just to let our listeners know a little bit about you?
When I'm not working, I'm a middle-aged man. I need to try to keep my health fit, so I have to do a lot of outdoor. I try to do some bicycling every now and then. I try to keep fit and try to keep healthy. And then, of course, we, as other people, have to do this ordinary stuff. So I'm not doing any special more than I try to be very active and be a lot out in the woods and picking berries and mushrooms in the summer. And yeah,
that's great.
Yeah.
What I also wanted to ask you, Dr. Johannson, is tell us a little bit about your research.
Yeah, as you said, I think if you look at my research, I'm doing a lot of psychosomatic medicine, and I'm into depression, cognitive behavior therapy. But I also started and also into the selenium and Q10 studies with complementary medicine, and I also done a lot. I also do some sleep research in cardiac disease and heart failure. But I started everything started with heart failure in my dissertation, and then I have worked as a heart failure nurse for many years. And I think this fluid paper came from my experiences as a heart failure nurse in first case and then we can add on my experience as a researcher later. So that's why I felt that we have to write something about fluid restriction, how to think about it. But I felt that this 1,500 milliliters was quite stupid.
And this paper that you were referring to, Dr. Johannson, I will put in the show notes and in the link descriptions of the podcast. But I was really interested. I read your paper about the fluid restriction, and what it really does is it tries to summarize the evidence that we have today, because at the end of the day, we don't have a lot of high quality evidence.
Yeah.
So as I said initially, fluid restriction is fairly widely recommended, especially in these symptomatic heart failure patients. Sometimes the restrictions can be fairly harsh. I mean, I've had patients that have come in being recommended 800 cc's of fluid at home, and they've been doing that for months to years. So it does have a significant impact on your quality of life. What I wanted to get at is, could you tell us the background of where this fluid restriction comes from, and then where we are today in this debate before we go into some of the studies?
To be honest, this 1,500, I have not found any papers about 1,500. I have not found any papers showing the evidence for 1,500. I think that is something that someone somewhere just found out, and that has become sort of a self-alive. Everyone uses it, but no one knows why they're using it. And we have been, when I started to work with heart failure, I was learned 1,500 is the way to go, even if the patients had a weight of 49 kilos, even if the patient had a weight of 100 kilos. So, and from the beginning, and you start to use it quite uncritically.
Absolutely. And it's exactly what you said. The guidelines by the European Society of Cardiology recommend that patients with heart failure should avoid excess fluid intake, and a fluid restriction of 1.2 liters per day is sort of for consideration in patients with pretty significant heart failure to relieve symptoms and congestion. On the other hand, you have guidelines from the Heart Failure Society Association that says a maximum fluid intake of 2 liters in patients with severe hyponatremia and in heart failure patients who demonstrate fluid restriction that is difficult to control on diuretics and sodium restriction. So they're not exactly saying the same thing here. So it's certainly something that I have been taught since medical school and began to question more so much later once I started my training.
Yeah, and I think exactly because when I started to work as heart failure nurse many years ago, we used 1,500 uncritically, and later on the latest year, after heart failure, we started to use 1,500. We never spoke about water, because we felt that the patient did not consume too much water. And sometimes, there are sometimes maybe some patients at a certain point of time, maybe who need fluid restriction because they're really, really, really decompensated. And maybe we never talked about water, and the patients never came back in excess of, with excess amount of fluid in the body. So from the beginning, I had a lot of patients complaining at first, but when we stopped using fluid restriction, we also have less patients complaining at first.
Yes, and that's very true. I mean, it is a symptom that a lot of heart failure patients will complain about, and at the end of the day, a lot of these patients are on diuretics, which tends to worsen a lot of their symptoms.
Yeah, and so we focus more in a heart failure clinic to learn the patient to use diuretics, but depending on their own weight, and if the soda started to accumulate water. So and then I think most patients, if they can learn to use diuretics, they also decreases the doses generally, and then it becomes less thirsty. You don't need to drink that much. So I think, from my point of view, I felt it was learning the patient to use diuretics more flexible, in a flexible way, according to what they're monitoring.
I think I agree with you on that. I think that a lot of these restrictions have been placed, and you have different diuretic doses in patients And you really just have to find the right balance. And I will say to the audience that the fluid restriction debate does not isolate itself to one setting in heart failure. It is two different settings where there are patients who are in decompensated heart failure, usually hospitalized. There is a question of fluid restriction in those patients, and then there is the other question on patients which forms a large majority of the patients out there living their life, are restricting their fluid day to day. If we go to some of these studies, and I know there's not a lot of data, but there is some data, how would you say that you define fluid restriction when it comes to these different studies?
I think it's very, very problematic because there are different levels of fluid restriction. One of the studies which I often use when I have a lecture, I use this, I don't remember the name, they used 800 milliliters in patients who were in a heart intensive care unit. And there are studies allowing up to 2,000 milliliters. So we have a big difference between 800 milliliters water and 2,000 milliliters water. So what is fluid restriction? Yeah, it depends on the study. I think the maximum level is about 2 liters.
Yes.
If we don't go to the study which was performed in Sweden, Marie Holst, who used this 70 milliliters per kilo body weight. And then we have the maximum level of 2.8 liters. So, and if you weigh 70 kilos, according to that, then you can drink 2.1 liters of water. So we are passing 1,500 milliliters quite excessively with that restriction.
I think that study you mentioned absolutely did restrict fluid in their patients to 30 milliliters per kilogram up to a maximum of 2.8 liters. So certainly I echo what you just said. My review of the literature really shows a very wide variation in this definition of fluid restriction. And then it gets to the challenge of how do we really define this and how do we come up with guidelines and recommendations for something that just has not been adequately studied. So one of the other things I want to go into is let's separate some of this data into studies that sort of show benefit. Then we'll talk about studies that probably don't show much in the way of benefit, and in the end try to summarize or bring all this data together and come up with a conclusion for our audience here today. There are some studies that do show benefit with fluid restriction, and I know they're not large. I know a lot of the data comes from this Italian group, which happens to be the group that has published several randomized controlled trials within this arena of salt and fluid intake. Could you tell us some of these studies that do report benefit with fluid restriction?
But that Italian study, it's a really complex study, and I know when I read that study, I had to read it a lot of time because I never got the clue really, but they also mixing between if the patient have too much salt or also they do many different combinations, and I think the most beneficial for him was drinking about 1,000 milliliters, and then also I have to look at the study because I don't remember it.
Of course.
Yeah. And they have a quite high doses of loop diuretics, and then
they do.
But they also had a normal sodium diet, and I think that a mixture led to hospital reduction, hospital readmission for heart failure, and also I think also the decreased the hormone activation as a BNP aldosterone. So there was something with that study, but I think these are really experimental studies. If you work live with decompensated heart failure patients, I think this is a quite complex regime to follow for the patients. Maybe but these were compensated patients, but we also have to work with how can we keep the patient adherent to a very complex regime.
And I think you're absolutely right. I will summarize the study for the audience.
When we talk about studies that reported benefit with fluid restriction in heart failure, I'd like to mention that most of them defined restriction around 1 to 1.5 liters, depending on the study. Unfortunately, the fluid intake and controls also vary quite widely. And none of these studies looked for survival differences and didn't really find any survival differences either. What they did report, there was a benefit in restricting fluid intake with an improvement in symptoms, quality of life, and reducing rehospitalization. The largest study was done by the Italian group that has published several other randomized studies in the field of salt and water restriction. They published their findings in 2009 in the American Journal of Cardiology, where they randomized 410 consecutive patients who had compensated heart failure, NYHA class 2 and above. I repeat, these were compensated heart failure patients. Patients were aged between 53 and 86 years, had heart failure with reduced ejection fraction of less than 35% and serum creatinine less than 2 milligrams per deciliter. These 410 patients were then randomized into 8 groups with roughly 50 patients in each group, and all groups had different strategies when it came to sodium intake, fluid intake, and diuretic dosing. The authors eventually noted that the group that had the best outcomes was the group that had normal sodium diet of up to 2.8 grams per day, limited fluid intake of up to 1 liter a day, and high doses of loop diuretics. They found that this group had a significant reduction in hospital readmission for worsening heart failure, which was the primary endpoint for the study. The secondary endpoint looked at neurohormonal activation, and the authors found that this group was also the best when it came to neurohormonal activation reduction. They looked at BNP, plasma aldosterone levels, plasma renin activity. All these results were significant at 6 months of follow-up for this combined strategy. You could argue that you could not necessarily generalize results from these 50 patients across all your heart failure patients. Also, what the study didn't do was they did not report the actual fluid intake, which is quite important when you're giving them such high diuretic doses. You're going to have these patients have increased thirst and other side effects from diuretics. It's important to see how many were actually compliant with a limited fluid intake.
Key here was that they were all compensated heart failure patients.
Yeah.
So we're not talking about these inpatients who come in with decompensated heart failure. There's really not much data there.
No.
I do restrict fluid in those patients in the hospital to some degree. I'm not going to do 800 cc's, but I'll do 1.5 liters, 1.8 liters.
Yeah.
Let them have their morning coffee, let them drink their water. But if they're thirsty, yes, they can have a little bit extra water.
Yeah, and I think that when we're talking about fluid restriction, if the patient has been hospitalized due to heart failure, they have an excess of water, that's a different question about fluid restriction. If we're talking about the compensated heart failure patient in the heart failure clinic, I think it's quite normal if you try to restrict fluid when the patient is decompensated within hospital. But anyway, we have this other study comparing 800 milliliters in decompensated heart failure patient intercept compared to liberal fluid regime. And there was no difference related to rehospitalizations. The only difference was that those with 800 milliliters had more thirst and poorer quality of life. So,
yes.
So from that study, it's not really evident that even if they have been hospitalized for heart failure, that study does not say there's any evidence of a restricting fluid in those patients, even if they're in intensive care unit for heart failure.
It's very true. And I think this study you're mentioning too did, like you said, have several hospitalized patients, looked at short-term endpoints, which is not unreasonable, didn't find any advantage to restricting fluid. And however, like you said, the sense of thirst and sort of difficulties in really adhering to this low fluid prescription is difficult in a lot of these patients, especially patients who were a little sicker.
And there also is another Italian group which we refer to in our paper showing that if you use fluid restriction, I don't say we not should use fluid, but we should use fluid restriction when we really have the motive for it. Not saying that all patients will have fluid restriction.
Yep.
Then we know that most patients with heart failure are old, And in Sweden, at least, we know that old people does not drink too much water. Most older people have problem to drink enough water.
Yeah.
And then we know if we have fluid restriction for a long time and they're still continuing to be on diuretics, then they can be below blood volume in the veins. And then we have a response from the body will be to accumulate water. So maybe fluid restriction in the long term could lead to accumulation of water.
Mm-hmm. Certainly can, if you're hypovolemic, play a role in more neurohormonal activation. Just to summarize what you said, I know we went over most of the data, but to summarize it briefly, in compensated heart failure patients, maybe there is some data, and again, not strong, that there may be a benefit.
In compensated heart failure patients who are living at home, I think we have not a lot of data evidence suggesting that they should be having a fluid restriction all the time.
Yes.
I don't think there's evidence to suggest that they should live on fluid for the rest of their life. But maybe we should have to educate the patient. Okay, but if you notice that, I have increased 2 or 3 kilos in 2 or 3 days, and I notice I have more fluid, then maybe the patient for 1 or 2 days should decrease the doses of diuretics. So we have to look. Sometimes I think this 1,500 milliliters depends on that we as a healthcare personnel have to have a little courage to power to the patient and say, can they use diuretics? Can they have fluid restriction at certain point of times, learning to do that by themselves? I think this is more a generalization.
Yep.
To summarize the findings in decompensated heart failure patients, though most of the studies have been small, none of them were able to show any benefit of fluid restriction to 1 or 1.5 liters in this population. Those patients did have greater difficulty in adhering to that fluid prescription because a lot of them were on high-dose diuretics in the hospital. I don't know if this will change the way I practice or change the way a lot of you practice, at least until more data is available. That was a great discussion, Dr. Johannson. Thank you for your time. I think it leaves us with a lot of questions at the end of this discussion, and that mainly highlights the lack of data we have in this field and the need really for more larger randomized control data that would help us make more informed decisions in the best interest of our patients.
Thanks a lot. Bye-bye.
That was the end of another episode that we had a lot of fun creating. Thank you for listening. We really appreciate it. Please do like and subscribe because it means a lot to us and it helps other listeners find us. You can leave your suggestions for topics, critiques, things we can do better. You can email us at heartsuccessteam@gmail.com. Reach us on our website, heartsuccess.info, our Facebook page at HeartSuccess Team, or my Twitter handle, CardioBro. Thank you, guys.